Hi, good evening, everybody. My name is Samuel Duri, and I'm a Director of Gastroenterology at Medical City for Military and Security Services in Muscat, Oman. And this is episode 15 of Muscat Endoscopy Academy webinars, and it's my great pleasure again to host my dear friend Dr. Zlatan Mujagic from Maastricht, Netherlands, where today we're going to be talking about ulcerative colitis and the role of endoscopy in ulcerative colitis. So, hi, Zlatan, welcome back. Thank you very much.
Well, happy to be here. Thank you very much for the invitation again.
Okay, so um, over the last few years, guidelines have kind of converged and moved in the same direction, where like talk about endoscopic healing is no longer nice to have. It is framed as a key treatment target that we must have it. And the problem is that many of us in real world practice are nowhere near hitting those targets consistently for all sorts of reasons. And so today is a very much a clinic and endoscopy first conversation. How do you actually use the scope strategically? We have more patients that we need to scope, how we should not always maybe chase the perfect mucosa, and how we should do if we see a little inflammation, and what will drive our endoscopy, like our endoscopic and therapeutic choices. So a lot of us now have heard about stride two and treat to target language, how it plays in the background. Endoscopic healing is always defined as Mayo endoscopic score and of zero, or the ulcerative colitis index of severity, UCEIS, of one or less on top of symptom control. From your perspective, you compare your practice, say when we first met, more than 10 years ago now, when we first met and we were still training, and now, has the emphasis on endoscopic healing actually changed what you do with ulcerative colitis patients, if at all? Are you truly treating to those targets, or have you adapted them to reality?
Well, yeah, I think it's an excellent question to start with. It has changed in many ways. In some ways, also it hasn't that much. We probably will also talk about it later, but you see this shift from subjective parameters, symptoms, towards more objective parameters. So calprotectin and CRP as biochemical parameters towards endoscopy, but nowadays also more and more towards intestinal ultrasound, which is less invasive, of course, than endoscopy. So you see these changes coming up, and I think indeed you mentioned the STRIDE 2 criteria. It's good actually to start with that. For those who don't know, the STRIDE 2 criteria are, well, STRIDE is selecting therapeutic targets in inflammatory bowel disease, and then the updated criteria, the two criteria, which were updated in 2021. The first one originates from 2015. Which actually are consensus-based criteria on what targets we have when we start treatments in IBD, so both ulcerative colitis and Crohn's disease. It's an international consensus of IO-IBD, and it specifies actually that the long-term targets is endoscopic healing. So then you need endoscopy indeed to see what the results of your treatments are. What I do like very much of these STRIDE criteria is that they take everything into account. So of course, for patients, symptom control is number one. You have abdominal pain, diarrhea, etc., and that's the reason why you go to your doctor. And what you want to have is not endoscopic remission. I've never had a patient who asks me, when will I get endoscopic remission? They ask when my pain will go away. And
Yeah.
so that's the first target. It's also short-term target of treatments according to the STRIDE 2. And then you have the intermediate targets, which is biomarker normalization, so normalizing or lowering of calprotectin and CRP. And then
Mhm.
long-term targets, which is endoscopic healing. And for that, you need an endoscopy. And for these short-term targets, so symptoms should, improve or go away within weeks. The biomarkers should normalize after 8 to 12 weeks in ideal world. And to see whether you reach endoscopic healing, then you need endoscopy somewhere in 3 to 6 months after starting treatment. Yeah, so that's what STRIDE 2 say. And actually, we are now starting also or doing a study here in Maastricht where we are looking into real world data. So looking into how often actually do we meet these STRIDE criteria in real world. And I still don't have all the preliminary data yet, but well, it's not that optimal as you would expect. And that's real world. All our drugs have a certain therapeutic ceiling. You have like 30% maximum effectiveness in daily world of all drugs, whether it's infliximab or upadacitinib or whatsoever. And that means that striving for the ideal world to have that endoscopic healing is not always possible. And then it's shared decision making and going from patient to patient to see how you what you will do with regards to treatment.
Mm,
So
yeah,
and
yeah.
maybe just to add on that, that's also what STRIDE criteria. That's what I also like very much STRIDE criteria. Not only that they take into account clinical remission, biochemical remission, endoscopic remission. The STRIDE criteria also emphasize personalization of treatment. So look at your patient. Is it an elderly patient who had cancer before, who had cardiovascular risks? That's a different scenario compared to a 20-year-old patient with ulcerative colitis who maybe also have PSC and thereby increased risk of cancer. So the second one, that's someone you want to have really in good deep remission if possible. The first one is someone you just want to treat as good as possible and balance, the benefits of treatments versus potential side effects on that in that age. Uh,
Mm,
so.
yeah. It's a very pragmatic and a very nice way of doing this, um, I usually like whenever I talk to patients and they ask me, so they say they're okay or sometimes say they're not okay, but quite often the question for the patient, they want to know from you how they are actually doing. And I always like tell them like, well, we talk about four things that we would like to achieve here. First is the clinical remission, which is like how do you feel?
Mhm,
How often you go to the toilet? How do you feel in general? Your overall quality of life and your specifically your bowel issues.
mhm,
And then we talk about the biochemical remission. I tell them like, so that's your fecal calprotectin and then your CRP and your iron levels and whatnot.
mhm.
And endoscopic remission is like when did we scope you last and what did it look like? And in best case scenario, in best of worlds, even histological remission. What does it look under the microscope? So these are the four things, these are the four pillars that I'll usually try to explain to patients to break it down to them in a simpler way to digest. So but problem is I think when we talk about endoscopic healing, it sounds very nice and neat on paper, but in the room we're often quite juggling these different scores and shorthand description. Some people may document Mayo scores, some people may use UCIS,
Mhm.
although I haven't seen it being used that much in my practice. Most people use Mayo score, and a lot of reports just report either like it's mild or moderate
Exactly.
inflammation or severe inflammation with photos, which
Exactly.
can be this is very subjective, right? So when you Zlatan, when you scope a patient that you see today, what do you actually put into the report? Do you routinely use Mayo or ECIS or is
I
it
think
more
that's an
important?
excellent question. Also, the way you stated it is actually also giving immediately also the answer. I use both, but we are also a research center for IBD, so we like to have both scores also for research purposes. Many of our real world data are used again also in different research questions.
Mm,
So for that, we try to incorporate both. But the reason why the Mayo is from the 1980s. It's actually developed specifically because the inter-observer differences that you have in reporting. And indeed, if you just indicate there's mild inflammation or severe inflammation, and you have a few images, it's quite difficult for a different doctor who hasn't done the endoscopy, hasn't seen it, then to decide what to do with this result. And
Mm.
specifically, if you want to follow up with a new endoscopy in a half a year, and then compare it to the first endoscopy, you have to have some kind of objective measurements on what you have seen there. So that's why actually the Mayo has been developed, well, decades ago, and it's the most used one and the most known one. In the beginning, it's quite not very well validated. Well, because in 1980s, we didn't have any, or at least that much strict scientific criteria how to validate a new score. But later on, because it's so overused in studies and in RCTs, etc., the validation is well, can we say it's quite well until now. Just for those who don't know it exactly, so it's a 4-point score. A Mayo of 0 is normal or inactive disease. Mayo of 1 is mild disease, which actually is described by erythema of the mucosa or loss of vascular pattern or decreased vascular pattern. Mayo 2 is moderate disease, marked erythema, variability, and erosions. So no ulcers, but erosions. And 3 is severe disease, spontaneous bleeding and ulcerations. And there are so the positive thing of the Mayo is that it's well quite well known, used in a lot of studies already, and it describes the severity of disease. There are also some downsides of the Mayo. First of all, it doesn't describe the extent. So you look at the worst affected segment and then describe the Mayo score, but that can be a short segment. And specifically in patients who are under treatment, sometimes if it's an index endoscopy, you would expect the worst segment be the rectum proctitis. Patients who are under treatment who maybe have suppositories, their worst segment could be in a few centimeters in the sigmoid.
Yeah.
And that's something different if you have a Mayo 3 in a short segment and the rest is Mayo 1 or Mayo 0. That's a different
Yeah.
patient compared to a pancolitis Mayo 3.
Yeah.
And we also see many studies that interobserver variability in the Mayo score is also not very good because, well, marked erythema versus erythema, what's the difference? Erosions versus ulcerations, how big should the erosion be? Well, and these are things that make it less reliable from observer to observer. And again,
Mm.
same thing, if you do a baseline endoscopy and a new endoscopy in 6 months, you want to be able to compare these endoscopies. It helps, but it's not optimal. And
Yeah.
so that's why actually the ulcerative colitis endoscopic index severity score, so the UCIS has been developed somewhere in 2012, I believe, and that's actually a comparable score which tends to be more reliable, specifically from observer to observer, looks about at the same patterns, so vascular pattern, bleeding, erosions, and ulcers, but as a more a larger score, it's 0 to 8. You score the different segments. Also look, of course, at the specific worst segment. Again, the same way as the Mayo score. That
Yeah.
determines how high it is, and then you have a score of 0 to 1, which is endoscopic healing. 2 to 3, it's mild disease.
Mm.
4 to 6 is moderate disease, and 7 to 8 is severe disease. And we try to use them both. Actually, I would say in general practice, it does not much matter which one you use, but it's good to use a score, one or the other. And it's good to train your staff and colleagues you work with that you do it the same way, because quite often the patient has a different doctor who's doing the endoscopy, and if doctor one does an endoscopy and puts the Mayo score and doctor two uses the UCIS, then then still not comparable. And you have to have the same interpretation of the scores when you're doing the endoscopy. So when your colleague does the endoscopy and patient comes back to you and you need to adapt your treatment, you have to understand what your colleague means by a Mayo score of 2 or 3.
Yeah. Yeah. I think it's always helpful to go back and before you do a scope on a patient with the UC, let's say this is a patient we've been following, it's always good to go back to the before you put the scope in the patient, is just to go back to the previous report and previous pictures and have a look
Yeah,
to get an idea
yeah.
of what it looked like back then, if hopefully it was well documented, so that you can actually also have like some sort of an objective comparison, because sometimes what's written in text does not
Mm.
match the photos, right? So Yeah, but this is really great. But let's talk about like this classic gray zone that I think we've all seen this. The patient feels well, normal stool frequency, maybe slightly raised fecal calprotectin or 100 or 200, or even 300, and a colonoscopy you see only mild residual erythema, Mayo score 1. In 2026, we're talking about chasing deep remission.
Yeah,
But we're also weighing the safety and cost and treatment fatigue in these patients, especially most of them, they become sick when they're quite young.
yeah.
So in that scenario, what factors push you towards escalating toward advanced therapy versus saying, this is okay, we'll monitor with fecal calprotectin and maybe defer another scope?
Yeah, yeah. Those and those situations are very much patient dependent. So I think shared decision making is very, very important there. That's also like to take time to explain patients what the treatment goals are before we start a treatment. So that's actually also what the stride two criteria indicate. You know, discuss your treatment goals with your patient and personalize your approach. If we talk about deep remission, you can discuss whether deep remission is endoscopic healing. So should you have a Mayo score of 0, UCS 0 to 1. Is that what we mean by deep remission, or should we also have histological remission? So if you don't see anything, but you take biopsies and the pathologist says there are still active inflammation, is that then not reaching deep remission? And nowadays, there's even something called molecular remission. So you have studies who focus on molecular remission. So that means that if you take biopsies, there's no active inflammation, but if you do additional molecular scanning, transcriptomics, and you see, your transcriptome, which is a pro-inflammatory, well, all these things from a research point of view and also from a prognostic point of view, they make sense. So it's an inflammatory disorder, and we know that ongoing inflammation, whether it's histological, whether it's visible, so endoscopic, leads to higher hospitalization rates, higher colectomy rates at the end, and higher
Mm.
chances of exacerbation of flares. So all these things are actually proven. So yes, indeed, it would be perfect to have a patient, in endoscopic remission, histologic remission, and even if you would say molecular remission. On the other hand, you also have to stay realistic with the medications that we have and the treatment options that we have. So the only way to get someone sometimes in perfect remission is to do a colectomy.
Mm.
Because the medication has a therapeutic ceiling. So you have to have the balance. And if you have a patient who has potential options to optimize his treatment, so if you just, if you're on a low dose mesalazine and someone still has mild active disease, you can step up with a higher dose mesalazine or even go to a higher treatment. That's something else compared to a patient who already had 6 drugs. So yeah, you started on a seventh one and you went from Mayo 3 to a Mayo 1. Then you're happy, you did your thing, and the patient has no symptoms. It's perfect. And the same is also when what I talked about previously. If you have a young patient with high risk of cancer, such as someone with PSC, that's someone to get that you want to get in deeper remission compared to 74-year-old with heart disease and diabetes and a Mayo 1 without symptoms. That's perfectly fine. I still
Mm.
explain to these patients, we still see some of the inflammation, but you're doing fine. The medication that you have is sometimes somehow balanced with regards to benefits and potential side effects. So let's keep it that way, and monitor it. Well, if possible, by biochemical parameters called protectin, and if it
Mm.
increases, we can always think about optimizing treatment.
Yeah.
But it's in general good also when you think about optimizing treatment is also look at pharmacodynamics. So if you use diaperins, for example, do your therapeutic drug monitoring to see what the trough levels are, how metabolization patterns are. So you can do things proactively. The same also for anti-TNF. Sometimes patients develop antibodies which can go away if adapting of treatment, or you should switch at anti-TNF. So there is an options to look at how your treatment is at that point. But if you think your treatment is optimal and this is the best you can do, discuss that with your patient and monitor.
Mm.
Yeah.
Mm. Yeah. Yeah. So
Personalization and
it's
shared decision making is
personalized.
the key thing, I think.
Personalize and tailor therapy
Yeah.
and discuss with the patient. Yeah, yeah, yeah. Fantastic. Yes, I fully agree with you. Um, Now if we shift gears towards the acute severe UC.
Yeah.
So acute severe ulcerative colitis, I think that's where endoscopy really earns its keep. I would say the guidelines more or less agree that every acute severe admission should get a flex sig in the first 24 to 72 hours
Mhm.
nowadays, both to score severity and also to biopsy for CMV, cytomegalovirus.
Yeah.
Um, in practical terms, when you're on the ward with an acute severe ulcerative colitis case, how does that first flex sig and its finding shape what you do on steroid day 3, and whether you look for CMV and routinely, and how quickly you move to rescue therapy like infliximab or cyclosporin, and like I mean we know that I mean unless you're in a big academic center or a teaching hospital, if you are suspecting CMV at the same time, you will not get the biopsy results in 3 days.
Well,
Can you walk us through your personal algorithm from the first scope to the rescue decision?
yeah, that's an important point that you touch upon is, acute severe colitis is an emergency situation for a patient with UC. And in most cases, in IBD, although it can be a very severe disease, people get very sick. In most cases, you can treat it an outpatient way. People have time to recover, so you have time to evaluate the effect of your medication or your therapy. Also, acute severe ulcerative colitis is a different thing. Things can go very fast. People have a high chance of colectomy. If you don't treat them well, they even have a chance of dying. So mortality rates are there. So it is an acute situation, and that's idea of scoping within 24 to 72 hours. Why it's 72? Because of the weekends, and not all hospitals have the options to do an endoscopy on Saturday morning. In our case, we try to do that endoscopy for everyone who has an acute severe colitis within 24 hours, even in weekends, because, like you said, also the CMV diagnostics take time, and that's actually the most important reason to do it, to take biopsies to check for CMV, because we know that patients who have next to their acute severe colitis also a CMV infection have a less good prognosis. And there's always this discussion: is a CMV just an innocent bystander because it can also be seen as a commensal in your gut microbiota, or is it adding to the treatment? But I think very important as a message, it's not a CMV colitis. If you have an ulcerative colitis, it's both. So if you have a positive CMV and ulcerative colitis, then you have acute severe colitis with CMV infection, and you should treat both. So I think it's a mistake then to find CMV, and sometimes it happens. That's why I'm saying this. If you find CMV, you still need to treat your ulcerative colitis, although treating ulcerative colitis is with immune suppressive medication, and CMV is an infection, so you need to treat it with, in this case, antiviral medication, but do it both rather than one or the other. And that's why you need early biopsies. And in our case, we also have trained pathologists. Indeed, in the weekends, we don't get the results, but otherwise, we get them quite often within 24 hours for the CMV infection. And when in doubt, it's better to treat it as a bystander than not to treat it, because we know that, like I said, if you have an acute severe colitis and concomitant CMV infection, the effects of prednisolone, so as your treatment, effects of your escape therapy, infliximab, or whatever, another one escape therapy as you use, are lower with existing CMV infection. So when you co-treat the CMV infection, your effects are actually comparable to CMV negative ulcerative colitis. So yes, it would be good to do the endoscopy early. That's one thing. The other thing is it helps also sometimes with your decision. So we know that if you have deep ulcerations during the first endoscopy, so severe MAIO 3 colitis, that has already a worse prognosis compared to a mild, MAIO 2 or even MAIO 1, because sometimes it happens. People come in clinically with the diagnosis of acute severe colitis, and they have a MAIA-1 colitis, and sometimes it can be due to, concomitant other diseases such as, having just, influenza, which can also, in combination with an exacerbation of colitis, mimic acute severe colitis. In any
Yeah.
case, it's good to start prednisolone early, so corticosteroids early, and go to step-up therapy if necessary at day 3 to day 5. Yeah.
Yeah, but okay, this is really great, and this is exactly what I usually do as well. But in that scenario where, like, let's say you go in and you see the severe colitis, it looks like Mayo 3, but you have like these punched out ulcers that remind you of CMV, and you take the biopsies, and now I'm going to put the patients on high dose steroids, obviously, or the patient is already on steroids since admission.
Mm-hmm.
And once I see this, I've taken my biopsies. I put the patient on ganciclovir IV while waiting for the biopsy results. And I also take CMV, PCR, and blood.
Mm-hmm.
Now, in that situation where, like, it's been 3 days. Well, it's just two scenarios that I'm going to give you now. So first scenario is 3 days have passed, and patient's response is suboptimal. Still like 10 bloody diarrheas a day, and nothing, not much is happening, and and he's already on ganciclovir, and now I need to make a decision. I need the patient, but he could have severe the CMV.
Mm-hmm.
What do I do? Do I just like what would you do? Would you just start infliximab regardless now while they have ganciclovir cover, or would you continue just with the steroids? And if you start infliximab as rescue therapy, do you start tapering the steroids right away, right as you give the infliximab, so that you reduce the risk of additional immunosuppression and
Yeah.
so on. What would you do? Like, I mean, in short, if you would say in a situation like this, I think many clinicians have faced this dilemma.
Yeah. Yeah, I think, well, those actions, the scenarios are great because they happen quite often. I think the most important thing is to follow the acute severe colitis guidelines, for example, the ECHO, and to put CMV as a column next to it. That's why I also tell my colleagues or my residents, you have acute severe colitis. This is a treatment strategy for acute severe colitis, and CMV colitis is next to it. So independently of your CMV colitis, you treat your acute severe colitis as optimal as possible. So you start with steroids nowadays, and then after 3 to 5 days, you decide, is my treatment optimal, and are these patients doing well? If they are not, you step up the therapy towards nowadays mostly infliximab as first line escape treatment. And I would always do that irrespective of the CMV status. Next to it is following up the CMV status when you're in doubt or where you have positive CMV infection, and you need the biopsies for that, because it's good to do also the blood testing for the PCR, but the PCR is not always positive, and even if it's positive, it doesn't have to be an active CMV colitis, so mucosal colitis, so biopsies are necessary. But if biopsies come back positive, treat parallel your CMV next to the acute severe colitis, but just go forward with your ulcerative colitis, acute severe colitis treatment, irregardless of the CMV infection rate, and treating more aggressively is in general less harming than treating too passively, because like I said, if it progresses fast, and then you will end up with a colectomy or even with complications, perforation or whatsoever, and that's actually worse than the possible complications of treatment. And in most cases, co-infections because of too much immunosuppressants are not that common. Of course, very importantly, depending also on your region where you live, you need to start your screening for tuberculosis, hepatitis B and C early, So we do that on day one when patients come to the ER. If it's acute severe colitis, we start already testing for tuberculosis, hepatitis, and then we start prednisolone immediately also day one. So you have to need that early because in a latent TB patient starting infliximab can go bad. Yeah.
Yeah, and the steroids in that case, what do you do? I mean, the steroid that
Oh,
steroid
the
that you're
tapering. Yeah.
giving
Yeah.
IV,
There's no.
do you press it down? Because I try to like, okay, I'm giving infliximab, I try to taper the steroids faster.
Yeah.
What do you do?
Yeah, indeed, that's an option. Mostly, we I do like to see that my patient is doing better at some point before tapering. So I usually don't start tapering immediately with the first infusion of infliximab. But if you see that a day or 2 days, 3 days later, the patient improves, then we start tapering the prednisolone. Yeah.
Yeah. Okay. And the other scenario that I think you touched upon, like, this discrepancy between what you see in the biopsy and the blood.
Yeah.
We like this biopsy that really makes the difference. I mean, seeing it in the blood, that may not mean anything. You have positive PCR in the blood. It's not as important as having it in the tissue itself, right?
Yeah, exactly.
Yeah,
Exactly. And
yeah,
just to give you an example, I had quite a severe, it was a Crohn's disease patient, but quite a severe gastroenterocolitis, CNV, in a patient who had quite a lot of immune suppressants because of, double immune-mediated disorders. So he needed different medications, and he really had at some point that's a very severe cytomegalovirus infection, and his blood levels always stayed zero. So he didn't have any positive PCRs in the blood levels, while his biopsies in the stomach, in his small bowel and large bowel were all positive for CMV. And after getting antiviral treatment, he improved very much. So that was actually the from in my cases the worst CMV infection that I've seen of the GI tract, which didn't have any positive blood tests. And you can also imagine the other way, if someone has a CMV infection in a different organ, you can have a CMV hepatitis, and then it can give positive blood tests without active mucosal inflammation in the
yeah.
gut. So yeah, I always do it both. So I always also take blood tests, but for the PCR, but actually your hematoxylin H&E staining, it's quite important there. Histochemistry staining is as well is quite important. Yeah. Quite
Hmm.
high sensitivity specificity. So yeah, I don't know, it's above 95%. Uh,
Hmm.
so that the pathologist can say there's a positive infection or not. Yeah.
Yeah, yeah, yeah. Okay, great. Yeah, yeah, we can deep dive even more into this, but let's move on to the next part, which I think is also important, endoscopic healing and histologic activity. So another scenario that's becoming more and more common as we treat mismatch between what we see and what the pathologist sees. And you've touched upon that. Endoscopically, the colon looks healed, MEA zero, no ulcers, but biopsies show histological activity. And as you said before, like, I mean, that endo histo mismatch, let's call it. You said you do not see it as a trigger to step up treatment right away. Sometimes you may accept it depending on like what the patient has been on before. And if the patient is like just on mesalazine, you just like, you can do something. But if the patient has been through so many biologics and has had like, failures to different therapies, you may be okay with that, with whatever the pathologist may say, as long as it looks good on endoscopy. Is that about right?
Yeah, I think currently the current guidelines, if you also think of the strike criteria, they don't recommend standard biopsies and also changing your therapy based on histological results.
Yeah.
And that's not because it wouldn't be beneficial. It's more because, well, the question is whether our treatment options are there for us to go to that ideal situation. But if there are quite enough studies who show that ongoing histological inflammation without endoscopic inflammation is associated to higher rates of steroid reintroduction at some point, higher rates of exacerbation, more frequent hospitalization, and higher risk of colorectal cancer, because we know that cumulative ongoing histological inflammation, so even if you don't see any endoscopies, is more strongly associated with development of CRC. So you could think about, do I need to step up the surveillance in these specific patients? But if you go back to the guidelines, they don't recommend that to do it in a standard way, because if you have that situation, patients without symptoms, your calprotectin is good, you do endoscopy, and for what reason you take biopsies and the pathologist says there's still active inflammation, it's quite difficult to say that the patient have this great drug for you, it works perfectly, you don't have any symptoms, everything looks good, but the pathologist says, well, there are still some
Yeah.
inflammatory cells there, let's change it. Because any change in treatment can also go downwards and lead to really active inflammation. So
Yeah.
that's an issue. It can sometimes explain, you sometimes see this discrepancy also in biomarkers, that you have higher calprotectin levels and endoscopically no inflammation, and you then take biopsies, you see still histologic inflammation. That can be maybe the reason for these higher calprotectins. And what we don't know for sure, we know that a certain number of patients still experiences GI symptoms during remission. It's about 30%. We also have
Yeah.
done quite a lot of studies on that topic ourselves, and we are now also looking into that, is that maybe that histologic inflammation leads to symptoms, because you can think about active inflammation in the submucosa where also the nerve endings are, that these nerve endings can stay sensitized or even get more sensitized due to these persistent histologic inflammation, which can lead to triggering abdominal pain or other symptoms. So maybe in the
Mm.
future that will be a treatment target. For now, the standard recommendation is not to put too much weight on it. Yeah.
Yeah, yeah. Unless you have a patient that is very prone to cancer, such as PSC
Exactly. So
patient,
that would
that's
be a
a
reason
different
to go,
population.
to try to step up your game, and also it depends also on your therapeutic options. Like I said, if you have the options to optimize the drug that the patient is at that point on, that's maybe low hanging fruit and a way to go. But if you're already at optimal levels of your drug, and then changing something would mean go out of class, well, that's a risky thing to do, because going out of class may worsen the situation. Yeah.
Okay. So this is fantastic. So if you now move, let's say, treat this patient and then like you start them on some advanced therapy and you move to this 12-week checkpoint, whether it's biologic or JAK inhibitor or small molecule or whatever it is,
Mhm.
many of us are scoping, at least using fecal calprotectin around that time to decide whether to stay the course or change strategy. So if a patient has a clear but incomplete endoscopic improvement or some still elevated fecal calprotectin compared to baseline, how do you handle that? Do you go straight to therapeutic drug monitoring at 12 weeks, dose optimization, shortening interval, or do you switch class early? Maybe
Yeah,
not,
well,
but
also in this case, it's quite important to know your patient, the medical history. If your patient didn't do very well last year, and now you started a drug and you see good improvement on all levels. So clinically by medical endoscopic, but you're not there after 12 weeks, so we'll give it more time, give it another 12 weeks to get in remission. If you have a younger patient and with still a lot of symptoms, you want to improve it more fastly, then you can also always try to optimize your treatment, and therapeutic drug levels can help. But actually, the most evidence is for anti-TNF and therapeutic drug levels. There's some evidence for ustekinumab, for vedolizumab. The evidence is not that clear how to use TDMs. For thiopurines, there is some evidence, of course, but specifically if you think about the newer drugs, the JAK inhibitors, the SMP ones, There's no evidence at all for the IL-23s as well. So in that case, your therapeutic drug levels are less useful. Uh,
Mm,
but it's all about, knowing your patients, looking where are you at that point. Is there any improvement? If there's improvement, it's always good to give it a bit more time to improve
mm,
further, unless you have options to optimize your treatment. Yeah. And
yeah.
switching to another therapy, going out of class, I wouldn't do that too fast. And that's something that happens, unfortunately, quite a lot. Is that,
Mm,
because we have more treatment options now, you go from one to the other. But at the other hand, it's a chronic disease, a lifelong disease in most cases, and you need to have options also in 2 or 5 or 6 years. So make sure that you treat your patients optimally, but don't lose the drugs too fast. Yeah.
yeah, don't shuffle through them too quickly. I
Yeah,
think that's very
exactly.
important, very
Exactly.
important, very important. That's what you may see some less experienced people do is like, oh, it's not working, let's just change. And that
Yeah.
in 2, 3 years time, they've gone through like 4 or 5 biologics, and then
Yeah.
you have nothing left. Yeah. How about dysplasia and an inflamed colon? I think this is one of the most stressful findings for
Yeah.
both us and
Agree.
the patient. I mean, given that you are doing a good surveillance colonoscopy,
Hmm.
I don't think that is something that is systematically trained how to do chromoendoscopy or surveillance colonoscopy. But nowadays, at least with high definition endoscopy, there's slightly better training and with the use of like AI now, like the Olympus Olisense is up and running, and they have there's one mode there that actually can help you see how the inflammation is looking like, and so on. So we're having better, I think we're becoming better at spotting at least these lesions that might be resectable rather than going straight to colectomy. So if you find a dysplasia in an area of active colonic inflammation in a UC patient, what is your step-up plan? How much do you push endoscopic resection? And in which situations do you lean towards surgery? So, like, I mean, in younger patients versus older patient. I fully respect. I understand it. Like, I mean, if I were to scope patient, if I see an active inflammation and I see like something that looks dysplastic, I would try to actually get that inflammation to heal before
Hmm.
I
Yeah,
actually
that's
do
indeed the
more
way to
about it.
go.
Yeah.
That's the way to go. That's also why what guidelines indicate. The preferred approach is endoscopic resection during remission. So you would like to have your surveillance, and actually also for the surveillance, you would like to have your surveillance in a quiescent moment of the disease, to do it in an optimal way, high definition endoscope, dye spray or virtual chromoendoscopy, which is apparently equal nowadays according to studies. Take your time. Clean colon, so good bowel preparation is important. And indeed, if it's active inflammation, that's not the best moment to resect that dysplasia, if dysplasia is there, because you have to be sure that your resection margins are good. So on block resection is always better compared to piecemeal resection if possible, of course. And in generally, IBD related dysplasia can be quite complex to resect because of the scarring, because of the changes in the mucosa around it. So
Mhm.
letting it do the resection be done by an expert is always preferable if possible, and it's always preferable to have that during remission. So take your time to put the patient in remission, but take your time in some boundaries, because you also want to have that dysplasia resected. Uh,
Mhm.
so if I see indeed active disease and potential dysplasia, or you take biopsies, you find this potential dysplasia, step up the treatment, try to get them in remission, follow up the biomarkers, and if the biomarkers indeed show that calprotectin is good, then do the endoscopy as soon as possible, and if possible by an expert, and resect the lesion as good as possible. Yeah.
What do you do in terms of like, I mean, you taking the biopsy in order to find it again? What do you do? Because quite often they're small. Do you put
Oh
a
yeah,
tattoo next to
it's
like
always
what do
good
you
to mark them. So put a spot where you have found the lesion or where you have taken the biopsy if possible. And it's always important to do a full endoscopy again, check for all because if there's one lesion, chance of having two or three lesions are also quite high. You know,
Mm,
and also in that case, if you already have dysplasia in some area, it's not. Recommended as a standard, but I always take random biopsies in different segments because if you have random dysplasia, that's a different topic, and then you have to think about really doing a colectomy
yeah.
because if you don't see the lesion that you need to take out, the chances of missing a lesion and of developing cancer in some point is quite
Mm,
high, and then you need to think about surgery. And if you think about surgery in ulcerative colitis, in most cases it's full colectomy
mm.
rather than segment resection. Yeah,
Yeah, yeah. I would probably say that like as an advice to endoscopy to like people who are doing this, if you're gonna see something in a biopsy and you're gonna put a small tattoo, just like
yeah,
use a minimal amount and try to put it on the opposite wall and like within a few centimeters from it so that like that ink does not dissipate and end up under the lesion
exactly,
because they are difficult as it is to resect. And if you get ink under them, that makes them even more difficult.
exactly.
Not to get too excited with the amount of ink to be injected, and to always keep in mind that if I'm going to resect this, then it should be easy to find, but I should not make things more difficult for myself or for whoever is going to do it.
Yeah,
So
yeah, I agree.
it's very, very important, and I fully agree with you. These lesions are quite difficult to find quite often, so that's why, like these that's why we have IBD endoscopists nowadays.
Yeah,
Nowadays, but of course, that's something that is in big hospitals. I mean, in smaller community hospitals, it's really difficult to have it that way.
yeah, yeah, I agree.
Uh, Let me Great, Zlata. So, final question. Where ultrasound can replace the scope, if we say, like, so many centers are now integrating intestinal ultrasound, and you're one of these people. I'm not. I don't know how to do bowel ultrasound, but I mean, you do it, and you've been pioneers in that sense in the Netherlands, and you use like the different scores. The what do you use? The Milan ultrasound criteria. What do you use right now? That's the only one that we have, right?
Yeah, the
Or
Milan ultrasound criteria they are also used by the IBUS, the International Bowel Ultrasound Association. Yeah, yeah.
yeah, this promise like there's fewer colonoscopies without losing control of disease. So from your experience in which you see scenarios can intestinal ultrasound realistically replace colonoscopy in a treat to target pathway?
Yeah.
Which situation do you still insist on getting a direct endoscopic look?
I think that's a very important, very actual question for for current day. We use it more and more. I myself don't do any ultrasounds, but I have a lot of colleagues who do it, and we use them in daily clinical practice. So I of course send my patients to for ultrasound and see them back, and it's replacing endoscopy in some ways, not in all. And the good thing is that the technique is improved, so the way of how doing the ultrasound, but specifically our criteria have improved. The training for endoscopists, sorry, for ultrasound users is improved. So when you think about the Milan criteria, so what we see is that there are good criteria. You know, what's active disease? It's a bowel wall thickness with 3 millimeters is then the cutoff point. More than 3 millimeters is active disease, and less than 3 millimeters is remission. You look at stratification of the bowel wall, the color Doppler. Then you can see how much blood is flowing towards the mucosa. Whether you can see the different layers there. So all these things are included in the Milan criteria. And there's also schooling, so we know what certificates specialist needs nowadays to be able to say, I can do an intestinal ultrasound according to the latest criteria. And it helps specifically for active disease. So when you're in doubt, when you want to follow up active disease, when there is a discrepancy between symptoms and biomarkers, that's actually a perfect reason to do an ultrasound. An ulcerative colitis, but also Crohn's disease. For ileum disease is very effective. Not all parts of the colon can be seen, so the rectum is not that visible. Rest of the colon is quite often quite good visible. But you have to also take time for it. It takes about 15 to 20 minutes, so you have to see all the segments. The same thing as you do with your colonoscopy, of course. And it's important to know it's not a replacement in any way for surveillance, because polyps, you can't see polyps specifically the flat ones on an ultrasound. So you still need to do your surveillance endoscopies, but maybe in the future, or actually we're doing it already now, replacing colonoscopy when we are in doubt and want to do an endoscopy. Then you can also think about intestinal ultrasound to see whether there's any active inflammation.
So nowadays, is it your gastroenterologists that are doing this or some
Both.
osteonographers?
Both. So we in our hospital, for example, we have specialized radiologists, but also specialized colleague gastroenterologists who are doing that. It's a bit difficult, so you can also always also think about incorporating it in your outpatient clinic. The only thing it's a bit difficult if you want to do it well, you need like 15, 20 minutes. And in most cases, your outpatient clinic is not, you don't have gaps of 20 minutes before between your patients in case you need an ultrasound to do it. So how we have organized it is that we have specific ultrasounds, outpatient clinics where patients come to the gastroenterologist for which we already know that they would benefit from an ultrasound, and the ultrasound is planned in the same line as the outpatient clinic. So you do the ultrasound, you have already the biomarkers, and then after the ultrasound, you have discussion with your patient on adaptation of treatment. And what we also
Mhm.
see in these ultrasound, classically seen ulcerative colitis is always thought of as a disorder of the mucosa, while Crohn's disease is a transmural disease. So that's the difference between the two. But we see actually with ultrasound is not actually the case. You see the whole bowel wall is quite often affected in active ulcerative colitis. It also changes our perspective on how we look at ulcerative colitis in general. So I think that ultrasound has really the potential to change our clinic. It does it already in some ways, but endoscopy is still necessary.
Yeah. So like, I mean, it's a fantastic, like it's 2026 and we have all the cool new stuff, but like quite often some of the oldest stuff available in medicine, such as like simple ultrasound,
Yeah,
can really make a huge difference. This
exactly.
is, this is great. So Zlatan is incredibly valuable, practical, and very grounded in reality. So for everyone watching, like this take home message from this, I think, is not to scope everyone more, but to use endoscopy with intent
Exactly.
to guide decisions and reduce uncertainty and specific personalized care for our patients. So, Zlatan, thank you so much for joining us again. And to everyone watching, thank you for being part of Muscat Endoscopy Academy, and we'll see you in the next episode.
Thank
Thank
you.
you,
All the
Zlatan.
best.
Have a good day.
Bye.
Bye.